Hi everyone. So in this video, we are going to discuss about some of the inborn errors of metabolism, which are usually asked in our university exam of pediatrics. So first of all, we have to start with the phenylketonuria. That is the phenylketonuria, that is most of the one mark questions are regarding this. What is the type of inheritance in the case of the autosomal in the case of phenylketonuria? That is autosomal recessive is the inheritance pattern in the case of phenylketonuria. That is most important one mark question. So inheritance of the phenylketonuria is autosomal recessive, and the pathology behind the development of the phenylketonuria is because of the deficiency of the enzyme phenylalanine hydroxylase or cofactor tetrahydrobiopterin. So this deficiency which results in the development of this phenylketonuria. The phenylalanine hydroxylase is usually that is used for the conversion of the phenylalanine to thyroxine. These are the enzyme which results in the conversion of phenylalanine to thyroxine. So because of this deficiency of this enzyme, there will be decreased conversion of the phenylalanine to thyroxine or the absence of conversion. So that results in the accumulation of the phenylalanine in the blood, CSF and tissue. That results in the clinical manifestation in the case of phenylketonuria. And what are the clinical features because of that? The symptoms of the phenylketonuria in the child which develops in the first few months of life, and the major clinical features like mental retardation, growth retardation, microcephaly, and dysmorphic features will be there. And there will be also presence of light complexion and enamel hypophysia. And one of the major characteristic finding in the phenylketonuria is the mousy odor in the urine. That is the if a question is asked and we found a word that is mousy or the urine, that is an indicative of the or suggestive of the phenylketonuria. Then how will you diagnose a case of phenylketonuria? That is, we have to look for the elevated phenylalanine levels and tyrosinase levels. Then also we have to go for Guthrie's test for a phenylalanine in the serum, and also we have to go for ferric chloride test for the phenylalanine in the urine. So these are the diagnostic tests for the diagnosis of phenylketonuria. Then the treatment option is we have to advise the patient to have low phenylalanine diet, and we have to supplement oral cofactor tetrahydrobiopterin. So that is all regarding the phenylketonuria. Then regarding the glycogen storage disorders. The glycogen storage disorders, which are an etiologically heterogeneous group of disorders due to defect in the synthesis and degradation of the glycogen, which causing glycogen deposition in the tissue cells. Usually, the glycogen is deposited in the hepatic as well as the muscles. That is that is usually the glycogen which are stored in the liver and the muscles. So, because of this defect, there will be increased accumulation of the glycogen in the tissue cells. So, there will be two types of and it is most inherited as the autosomal recessive, except type 9, that is X-linked recessive. So depending upon the organ involvement, we have two type of the glycogen storage disorders, that is hepatic glycogenosis, and there will be myopathic or the muscular glycogenosis. These are the two types of the glycogen storage disorder. In the hepatic glycogenosis, it present classically with the hypoglycemia after short periods of fasting, where hepatic glycogenosis is the accumulation of the glycogen in the liver. So the hepatic glycogenosis is due to the accumulation of glycogen in the liver, and it is manifested or present classically with the hypoglycemia after short periods of fasting. And also the myopathic or the muscular glycogenosis, which is usually present with the cramps, weakness, stiffness, or the rhabdomyolysis. So that is all regarding the muscular glycogenosis and hepatic glycogenosis. And also in the hepatic glycogenosis, there will be lactic acidosis and doll-like facies, hepatomegaly, and short stature. And the usual types present in the case of types in the hepatic glycogenosis are the 1, 3, 4, 6, 8, and 9. The 1A is called the von Gerke's disease, and 1B and type 3A is called the Cory's or the Forbes disease, and 3B and 4 is called the Anderson disease, and 6 is called the Hertz disease, and it is usually present with the hepatomegaly and hypoglycemia. And there will be also presence of protuberant abdomen due to the marked hepatomegaly. Then in the myopathic or the muscular glycogenosis, we have the type 2, 5, and 7. The type 2 is called the Pompey's disease, and type 5 is called the McArdle's disease, and type 7 is called the Taro disease. So these are the classification of the glycogen storage disorders. Then about the galactosemia. So galactosemia, it is a there are three disorders of galactose metabolism, but it is the deficiency of the enzyme galactose 1 phosphate uridine transferase. That is, galactosemia is mainly due to the that is classical deficiency of the galactose 1 phosphate uridine transferase. That is GALT enzyme. That is, galactose 1 phosphate uridine transferase enzyme deficiency leads to classical galactosemia. And because of this deficiency of the galactose 1 phosphate uridine transferase, there will be the accumulation of the galactose 1 phosphate and other metabolites that have toxic effects on the liver and other organs. And usually the patients are normal at birth, but by the 3 to 4 days of breast milk or formula feeding, it shows the life-threatening disease with the vomiting, diarrhea, and poor weight gain. And the jaundice, coagulopathy, and liver dysfunction, which are the progressive and appears at the end of first or second week of life after the intake of the milk or the formula feeding. So at the birth, the patient is normal. Only by the 3 to 4 days of breast milk or the formula feeding, the life-threatening disease have to develop. Then the disease which may present initially with the indirect hyperbilirubinemia due to the hemolysis, secondary to high levels of galactose 1 phosphate in the erythrocytes. Because of these high levels of accumulation of galactose 1 phosphate in erythrocytes, there will be hemolysis that is leading to indirect hyperbilirubinemia in the case of this patient. And the many affected infants die of the E. coli sepsis in the neonatal period itself. The untreated infants, if surviving the neonatal period, have the persistent liver disease in the future and also cataracts and intellectual disability. And the diagnosis of the, how will you diagnose the case of the galactosemia? The diagnosis is confirmed by the elevated RBC galactose 1 phosphate concentration that is greater than 10 milligram per deciliter is an indicative of the classical galactosemia. And also we have to go look for the reduced RBC GALT enzyme activity that is absent or less than 1% enzyme activity in the RBC. And also we have to go for DNA analysis. And also a negative urine dipstick by the glucose oxidase method with the positive Benedict's reaction indicates presence of non-glucose reducing substance such as galactose or the fructose and is useful bedside screening test for the identification of the galactosemia. And then regarding the management of the galactosemia, if the diagnosis is suspected, galactose containing feeding should be discontinued. That is, all the galactose containing feeding should be discontinued immediately and replaced by the soy-based or lactose-free formula. And early and timely initiation of therapy results in the resolution of symptoms and prevent the complication. The galactose restricted diet is required throughout the life. And the disorder is being screened through newborn screening program in the various states in India also. So that is all regarding the galactosemia. That is because of deficiency of galactose 1 phosphate uridine transfer. That is the most important 1 mark question also. It is an autosomal recessive condition. So the next is regarding the So another important topic is the G6PD deficiency. So the most common 1 mark question is the what is the inheritance of the G6PD deficiency? So it is an X-linked defect that is more common in the males. So usually the glucose 6 phosphate is converted into 6-phosphogluconic acid with the presence of the glucose 6 phosphodehydrogenase enzyme, and it will convert the NAD to NADPH, NADP to NADPH, and this NADPH is which maintains in reduced GSH and which protect against oxidant disorder. That is the major metabolism of this or mechanism of this G6PD. So because of this absence of the G6PD, there will be accumulation of the glucose 6 phosphate and the NADPH is not formed, and there will be free radicals are produced. There is no protection against oxidant stress. That is the pathophysiology behind this disease. Then agent precipitating hemolysis are antibiotics like sulfonamides, dapsone, chloramphenicol, trimethoprim or sulfamethoxazole nitrofurantoin. These are the antibiotics which precipitating hemolysis, and antimalarials are the primaquine, chloroquine, pamaquine. Then chemicals like benzene, naphthalene, and others like vitamin K analogs, methylene blue, dimercaprol, acetyl salicylic acid, the phenazopyridine, and the infections like infections like hepatitis and sepsis, diabetic ketoacidosis, which are all of the precipitating factor for the hemolysis in the case of the G6PD deficiency. And the clinical features of the G6PD deficiency is it is usually that is in the newborn period, it is usually present with the neonatal jaundice because of the increased hemolysis, and mostly it is asymptomatic, triggered by the precipitating factors like hemoglobinuria, anemia, and jaundice. And the diagnosis by there will be acute fall in the hemoglobin and hematocrit. So it is a diagnosis indicative of the diagnosis of the G6PD deficiency. Then in the peripheral smear, we have seen Haynes bodies, that is precipitated hemoglobin or the white cells. Then G6PD enzyme activity less than 10% of normal is indicative of the diagnosis of the G6PD deficiency. And treatment, we have to avoid the precipitating factors, and severe hemolysis occurred, we have to give the supportive therapy as the blood transfusion. So that is all regarding the discussion on the inborn errors of metabolism. Thank you.